The second part of my talk has to do with diarrhea. Now, this complicated illustration um, shows that in the GI tract, starting from the liver to the stomach to the small bowel to the colon, all kinds of problems occur in the critically ill patient. The medicines we give also affects the hormones in the GI tract. The bacteria in the colon get altered. Bacteria that are normally not present in the stomach and in the small bowel also get altered. I realize the print is very small in this slide, but it is just to remind you that it is not unusual that patients develop diarrhea in the critically ill situation. Another fact that we have to keep in mind is that we have a plethora of organisms in our body. The esophagus usually does not have any bacteria of its own, only from food and the oral cavity. But the duodenum has 10 to the power of 3 to 10 to the power of 4 colony forming units, CFOs. But as you can see, as we go down from the stomach to the jejunum to the ileum and the colon, in the colon, it is 10 to the power of 10, 10 to the power of 11 or 12 colony forming units with good bacteria and bad bacteria, as you will see in this slide. The red guys are the so-called bad guys, Pseudomonas aeruginosa, Proteus, Clostridium candida, and they can produce carcinogens. And these can produce both constipation and diarrhea, liver problems, encephalopathy. But on the other hand, we have these nice guys, lactobacilli, bifidobacter, and also not all E. coli and enterobacter and Bacteroides are bad. They stimulate the immune function, they help in the digestion and absorption of food and minerals. It is the inhibition of harmful bacteria that is the main role of these good bacteria. So let's keep these two in mind, the pathophysiological changes and the GI tract issues. Now, the blame of the blame is always put on the enteral feeding when a patient has diarrhea. But then there are 24 definitions of diarrhea. The day shift nurses say that the patient is fine, but the night shift comes in and says that, well, the patient has diarrhea. Up to 6 semi-solid stools per day does not constitute diarrhea. Many normal people have 4 to 5 stools every day. So the interpretation is difficult in the clinical situation, and the interpretation of the literature also becomes very difficult because there is no standard definition for diarrhea, or at least there is no standard definition that could be used in clinical practice. And way back, over 2 decades ago, this paper in Nutrition Journal says diarrhea occurs in tube-fed patients not because they are tube-fed, but because they are patients. And tube feeding is coincidental. There is always another cause for the diarrhea. Don't let anybody blame you, the nutritionist or the clinician, that the patient is having diarrhea because of enteral feeding. Now, what do you do if the patient has diarrhea? Well, if it is increasing in severity, the first thing you need to do is make sure it is diarrhea. It can be fecal impaction where there is hard stool in the rectum, proximal to which the liquid stool actually comes around the impacted stool. So indeed, the patient does not have diarrhea at all, but it is constipation, and fecal disimpaction is the way to do it. Now, you look at what is the concentration. Is it 2 calories per cc or 1 calorie per cc, the standard? What is the rate? Is it continuous or is it a bolus feeding, which is very commonly associated with diarrhea? Is lactose in the contained the product that is used, although it is not really necessary to always use a lactose-free enteral product in critical illness. We have found that very often the diarrhea is because of medicines that the doctors are giving. The patient may actually be on medications such as milk or magnesia, and then the complaint is that the patient has diarrhea and the blame is on enteral feeding. Prokinetic agents that we have talked about can cause diarrhea. Potassium chloride, when it is given as a bolus through the And nasogastric or the nasojejunal tube can cause diarrhea because it contains sorbitol, and the sorbitol produces diarrhea. When you give electrolyte powders or salts, that can also produce diarrhea. Now, here is a study that shows that has compared continuous enteral feeding versus bolus feeding. And as you can see in this forest plot over there on the top, you'll see that the continuous feeding actually favors less diarrhea. So in the experimental or the bolus, there seems to be more diarrhea. And this was about 550 patients involving 7 studies. Now, when you use continuous feeding, also, this is the time to tell you that think about volume-based feeding. Rather than saying cc's per hour, the nurses are instructed to give, let's say, 1,000 or 1,500 cc over 24 hours, and the rate is adjusted. So if the patient has diarrhea, you don't have to stop the feeding. All you have to do is cut down the rate and then increase the rate a little bit later. One of the big problems why diarrhea occurs is bacterial contamination. This slide actually shows that 4 hours after the food leaves a hospital kitchen prepared diet preparation room, the bacterial content is so high that if this was a restaurant, the restaurant will be closed. And yet you will find that the patients in hospitals are getting this. This happens very often with hospital prepared, blenderized, kitchen prepared diets, which should never be used in the hospital, especially in the critical care unit. So prevention of bacterial contamination is a crucial step, not only when you are forced to use kitchen prepared diets, but also when scientific formulas are used. It has to be mixed. The powders must be mixed with sterile water. The containers must be changed every 48 hours, preferably every 24 hours. The hang time should be less than 6 hours. So prevention of bacterial contamination is a major problem. Now, in certain patients, I agree that micronutrient deficiencies like vitamin A, nicotinic acid, or zinc may also cause diarrhea, and the diarrhea can make these deficiencies even worse. But these come down the line while you are working up the patient for the cause of diarrhea. Questions are often asked, does a soluble fiber help in the prevention and the treatment of diarrhea? Now, over 20 years ago, it was clearly shown that soluble fiber decreases diarrhea. And this was shown very clearly because the soluble fibers, in contrast to the insoluble fibers, go into the large bowel to produce short-chain fatty acids, which are acetoacetic acid, butyric acid, and propionic acid. And these acids are actually the fuel for colonocyte growth. The colonocyte absorbs water and the sodium chloride and other electrolytes much better. It also produces lactic acid, and this low pH inhibits the growth of pathogenic bacteria. So the current guidelines, there's no change from the 2016 guidelines. Soluble fiber for persistent diarrhea is recommended. Now, however, if bowel ischemia or severe dysmotility is suspected, then fiber shouldn't be used. If all other causes have been ruled out, peptide-based formulations are used. Otherwise, the usual formula can be done. Another question is asked, do probiotics help? Now, here is a very recent study in critical care medicine, 65 randomized controlled studies, over 8,500 patients. No effect on the frequency of diarrhea, no effect on the duration of diarrhea. Probiotic organisms, unfortunately, are found in sterile sites as a sole organism. In other words, the probiotics have gone through the small bowel and the large bowel mucosa and have actually been grown in the blood. In non-sterile sites, it becomes the predominant organism. Now, there is a questionable benefit to decrease pneumonia and length of stay, but this is based on low certainty evidence and a high risk of bias. So the concluding remarks for my brief talk are, first of all, make sure that the patient has diarrhea. Don't blame enteral feeding. Check medications. Check the method of feeding. Change to continuous if necessary. Change the formula only if appropriate. Make sure sterile precautions are followed. Work up for other causes such as Clostridium difficile infections is done at a future date when enteral feeding problems have been solved. Thank you very much.